One of the things that new nurse leaders struggle with is creating or managing a budget. We are in a world where we have to try to balance the effects of good patient care and the bottom line. And the bottom line is much harder to achieve nowadays with value at the forefront. Volume doesn't mean as much as it used to. So let's talk a little bit about this today. Learning objectives. Identify the minimum staffing impact on budgeted numbers. Recognize how nurse leaders use units of service when they discuss this with other departments, especially finance. Recall sources used to build the nursing budget, and learn how to use the patient classification system to justify your staffing. The fight over establishing minimum nurse staffing has gone on for years. There always seems to be a disconnect between administration and nurses. Administrators are trained on running healthcare as a big business, whereas nurses focus on patient care and establishing high professional standards. As nurses, we feel the effects of low staffing. We become tired, we feel as if we aren't providing the best patient care, and perhaps there's that fear that our professional license will be reported if we make an error. Both sides need to understand the effects of low staffing and low revenue. Perhaps the motto, no money, no mission, explains why administrators push staffing and admissions the way that we do. Benefits of minimum staffing, well, those are quite obvious. The term value is more important now than it ever has been before. As insurance looks to reimburse based on outcomes versus volume, the case can be made that more skilled nurses will produce better results, thus providing the organization with better reimbursement. While this may be true, we must remember that the nursing shortage, many nurses and travel nurses are getting paid very well. A prolonged use of agency nurses or staff in overtime greatly erode the bottom line. Nevertheless, a well-staffed hospital will see fewer complications, lower mortality, lower readmission rates, shorter lengths of stay, and higher patient ratings. However, staffing costs remain the largest line item on any nursing budget. Keeping this under control is essential to generating revenue and supporting the mission. Budgetary effects on minimum staffing. Minimum staffing makes it much more difficult to meet budgeted numbers. When hospitals are unable to find enough staff to work scheduled hours, agency nurses are then needed. Consider today's average agency bill. That runs between $65 and $85 per hour. Now, granted, that doesn't all go to the nurse. It covers mostly the employee wage, but there's other costs associated with running an agency, such as travel, reimbursement, health insurance, licensure, recruitment costs, company overhead costs. Even when travel nurses aren't used, there will be a higher rate of overtime for the staff on the floor that are picking up the slack to fill vacancies. This also can erode the budget. Minimum staffing versus acuity. Not all patients require the same level of nursing care. Staffing ratios vary greatly between the ICU, to step-down units, to long-term care. So determining the appropriate nurse-to-patient ratio isn't always as easy as it should be. Leadership should examine the workflow from the last year, examine the trends in patient needs, the people that are coming through the door, and then adjust as necessary. Determine what's considered safe while also being budget conscientious is important. For example, could safe care be supplemented safely with additional nursing assistants versus nurses, or even hospitality aides like sitters? For leaders in long-term care, services can be assigned based on the average amount of time needed to complete a task. Add up the time that you spend providing the care the previous week, and then you can gauge how many staff members are needed to fill those 8-hour shifts the next week. Another idea is using a patient classification system based on assigning a number to a patient, such as a 1, 2, or a 3. The number of patients assigned a higher number will trigger the need for additional staff. Keeping a close eye on the patient classification system will allow for that prompt adjustment to staffing and maximization of your revenue. Setting up a budget is complicated in healthcare, but in many ways, it has to work like our budgets at home. Consider the anticipated revenue and the cost to operate. You're going to get revenue, but you have to send money out because of cost. The goal of every organization is to make a profit, but more importantly, to at least break even. The break even analysis uses a graph to analyze the revenue versus the cost versus the fixed cost. So the place where all those three lines meet and intersect give us that break even point. Now you have to adjust for variances quickly. So consider how the pandemic brought a halt to elective surgeries. Staff needed to be laid off quickly or financial losses would occur. So when setting up a budget, consider the population being served. A greater ability to accept fewer Medicare or Medicaid patients and more private insurance patients will result in greater revenue. Units of service. So comparing volume to hours spent is a way to measure the productivity on your unit. Units of service refer to specific patient services provided, more specifically measuring them over a period of time. This concept is essential when considering productivity on a unit. For example, a morbidly obese patient needing a CT scan is going to need more than one staff member to move her onto the gurney for the exam. Likewise, utilizing additional staff will take away from other patients needing the same procedures. Productivity then deteriorates, while at the same time it's not likely that insurance will pay for additional staff members to assist. You kind of have to eat that cost when more people are needed to provide a unit of service. So what's the nurse leader's role in units of service? Well, they're monitored by the manager. The manager will work firsthand with the floor staff to determine how long a service takes and the variance between services. Gather the data, determine what a safe staffing level is, and then use that in your discussions with upper management. Let's just relate this to long-term care for a moment. In my role as director, a unit of service may reference the task and time that it takes to change a resident's brief, assist with feeding in the dining room, provide the morning medications, or assisting with a bath. Sadly, because of poor funding and reimbursement, many nursing homes have a cap on the number of staff that they can provide per shift, even if the acuity is higher than expected. Thanks to the new patient-driven payment model, which we'll discuss a few slides in, our ability to provide cares based on acuity will give the nurse leader a greater ability to justify the staffing levels when talking with administration. No longer is resident volume or therapy minutes the goal of PDPM. Nursing-related tasks, specifically the patient as a whole, is now the forefront. So the classification system will help gauge the units of service and how to staff that building for years to come. So how do we interact with the finance department? Well, budgeting requires the nurse leader to be honest about the services provided, the cost, and how to advocate for the best, the patient receiving those services. So finance is a department of numbers. They see the end result, but not necessarily the time and sweat that goes into the service. So justifying the unit of service means explaining the time and manpower needed to complete the service and much of the work done in the back end, like the charting. My former medical director was often frustrated when he needed to see 25 patients per day in the clinic. Often those numbers are set by placing a visit at 15 minutes and then multiplying by the number of hours that person's working. The frustrating part is that there's a significant time spent charting, dictating, and patients showing up with one reported problem that will apparently take 15 minutes turns into 10 problems once they open up that can of worms with the doctor and reveal their true reason for being there. So it might be beneficial for everyone to look at unit averages to gauge the time and energy to complete a task instead of looking at what's just appropriate on paper. Building the budget will revolve around the biggest cost, staffing. The nurse leader must be prepared to be competitive with hospitals in the surrounding area to attract the best and the brightest talent, which means you might have to pay a bit more. So examine the going rate in the area and the positions that need to be filled. Include total costs for the staff member, which would be orientation, paid time off, salary, medical benefits. Examine previous and anticipated patient volume, so the year before, current year. Building a staffing group takes time. So the largest patient volume may not be present right away. So the ability to staff up over the course of 6 months or so might be the best option if you're starting up a new unit. Finally, consider a budget dedicated to per diem staff if staffing becomes tight. And then really look at that break-even point between keeping a unit fully staffed with agency and keeping a unit full with patients. At what point is it worth it, and at what point is it not worth it? What are some sources that you use for building a budget? Well, the first one is patient demographics. So what kind of unit is the manager employed on? Is it a private pay assisted living, or is it an ICU or step down unit? The type of facility and type of unit will determine the level of staff that's needed. In a hospital setting, one might consider preparing to manage pandemic related workloads or seasonal infections such as RSV. So if it's the fall, you might want to look at staffing up your unit in anticipation for that RSV or that COVID. So depending on the location within the country, more staff might be needed at a certain time of year. Also, in long-term care, consider winter. That's when everyone's falling and breaking their hips. It's a bad thing for the residents. It's a good thing for long-term care. You might want to staff up. Sources for building a budget, let's also include equipment. So inflation has changed the way facilities view equipment. Waste needs to be minimized and cost-conscientious vendors need to be chosen to keep those costs at bay. So everything from pens, office chairs, IV tubing, all that has a category in that overall bucket. Some categories might differ based on whether it fits into the operational budget or the capital budget. Interdepartmental charges. Each unit, they're not separate entities. They don't act alone. There are other departments who assist with the care. So for example, the pharmacy sends up medications for nursing home residents who are skilled under Medicare Part A. In my previous facility, the nursing home was responsible to pay about $20,000 worth of monthly expenses for medications for the transitional residents under Medicare Part A. Other medical supplies might fall under that same category if you have an all-inclusive reimbursement system. Revenue. So revenue does not flow through the system the same. For example, patients have a variety of different payer sources, Medicare, Medicaid, private insurance. So some companies need to work to balance the payer sources that they have. For example, Mayo Clinic has to work to limit Medicare, Medicaid payer sources by turning down new prospects when appropriate. Dentists despise the use of South Country Health Alliance as a payer source because they're unable to reimburse at an amount to cover labor and expenses. Generally, current patients will be grandfathered in those cases to allow South Country Health Alliance, but new patients are placed on the waiting list. Sometimes that could be even years. In the same way, a long-term care community needs to budget revenue by deciding how many transitional care patients to take versus long-term care patients. A patient classification system, if you do it right, is difficult to argue with. The nurse leader needs to have evidence to back the care policies to support patient care needs. Evidence shows that safety leads to better outcomes. We know that. We talked about that. With positive outcomes comes additional reimbursement because the quality measures are met. For example, if a nursing home initiates a performance improvement project, also known as a PIP, and successfully meets the changes over the course of a 1 to 2 year time frame, they'll receive extra money per resident day. This increase in funds could be used to fund other nursing improvement projects or additional sources on the floor, resources on the floor, I meant to say. So if a unique patient classification system aids in determining the appropriate staffing levels and delivers results, that evidence should be taken to the finance team for consideration. Remember, finance people are numbers driven and results driven. They want to keep the facility in the black and not deviate from that mission. So here's the patient classification example. PDPM, patient-driven payment model. In this model, patients spend time in the therapy department. They're no longer the driving force for reimbursement. Instead, reimbursement is determined based on patient diagnosis. Neuro tends to pay better, for example. So cognitive status, non-therapy services such as wound care, physical therapy, occupational therapy, all of that goes into this big holistic approach that PDPM takes. So this might encourage facilities to accept the harder residents of staffing permits instead of the easy ones. The acuity gauged through the MDS will help the administrative team determine the best nurse to patient ratio based on the acuity. Factors that the finance team will consider. So when you go running to the finance team and say, hey, we need to do XYZ, be prepared to bring some objective data. The nurse leader has hordes of objective data to bring to the finance team. Many of these reports contain objective data with proper funding that may contribute to a healthier budget. For example, previous health department surveys may show deficiencies in staffing or resident care. Perhaps care was poor because staffing was poor, and that resulted in a tag. So if the health department came in and noticed that resident nails weren't being clipped or residents weren't being bathed, maybe it was because the staff spent too much time giving the more essential care, like toileting, turning, repositioning, de-escalating resident behaviors, instead of getting to the things that could potentially wait, like bathing and clipping nails. There are research studies out there which guide facilities on how to properly staff. For example, CMS 1995 to 1997 Staff Time Measurement Study. Take a look at that. Time spent providing care will be more if resident care needs are higher. Some charting programs have this feature that allows staff to input the time spent for cares. So this could aid in determining the FTEs needed to safely staff. The staff turnover report is another good one. This provides evidence of a healthy working environment. High turnover prompts the team to make staffing changes. A few others I want to talk about: hospital readmission rates. So every facility has room to improve those quality measures. Any facility below average on their CMS report would find it in their best interest to apply for a quality improvement project. So starting quality department takes time and resources as the additional staff have to be hired, but in the end, decreasing the hospitalizations, the sentinel events, the miscare, all of that will pay dividends with proper education. Finally, let's face it, a nurse leader will have limited success with a finance department unless the administrator is able to view the nursing world through the eyes of the director. Any nurse leader should work to maintain a healthy relationship with the healthcare administrator, meet to discuss patient care issues, propose solutions that will maintain healthy staffing for the long haul. The administrator and the director of nursing need to be married, so to say, and they need to learn from each other, and they need to advocate for what they collectively feel is right. One should not be way off in Timbuktu and another one over here. They need to be together in their thinking. Conclusion: minimum staffing requirements hurt the bottom line when overtime and agency are calculated. Determine that break-even point for the use of agency versus your census. What might be right for one facility might not be right for another. Set up budget utilizing essential information, so revenue, equipment, interdisciplinary charges, equipment, and then join forces with administration and finance using clear, objective data to build a case for better staffing. These are the references used to help build this presentation. I really appreciate you taking the time to listen. I hope you learned something. Have a great day.